So we're in the last quarter of the semester. The next topic that we have is cancers. I specifically use the term cancers as opposed to cancer because even though they share a similar pathology, which is they can't stop dividing, they are very different in how they present. Patients 20, 30 years ago would talk about the big C, and if you got cancer, you were automatically going to die. But we now know there's many different types of cancer. They all have some similarities, but also have some pretty substantial differences. So how does the cancer develop? Well, we have to think about how normal cells develop because cancers basically develop in a similar way, but again, they never switch off. Most people, their cells will divide 16, 18, 20 times, and then they'll stop dividing. That's called apoptosis. Cancer cells keep dividing, and when they keep dividing, they get bigger, and when they get bigger, they take up nutrition that other cells should have, and they start damaging other cells. So again, normally stem cells are formed in utero, or they have various other types of stem cells that still exist in adults. But they basically differentiate into a type of organ cell. A prostate cell is formed from various types of stem cells, but then it becomes a prostate cell, and then it divides a number of times, and then it stops dividing. Cancer cells keep dividing and they create growths. We call those malignant, and those which are growths but are not quite as out of control, we call benign tumors. Cancers have poorly defined margins. They're not encapsulated. Benign tumors are usually well encapsulated and have very well defined margins. We have to be careful thinking of the word benign because usually we think of the word benign meaning harmless, but you can actually have a benign tumor, meaning non-cancerous, if it occurs in your brain, something like an acoustic neuroma, it actually takes up a lot of space, it pressures on things, and it's nowhere near harmless. It can actually be very harmful. But it's much easier to treat because it is encapsulated and it can be removed. Hyperplasia is when there's an overgrowth of normal cells. Benign prostatic hyperplasia is an example of that. Many hyperplasias are hormone dependent. A metaplasia, however, is when one cell basically converts into a different type of cell. This occurs in the lungs with chronic irritation from smoking. The cells which normally form hairs on them will turn into cells that don't have hairs. That makes it harder to clear sputum, and therefore the sputum builds up, and you get this nasty, disgusting, dark-colored sputum way down deep in the lungs. Another example of that is with Barrett's esophagus. People with esophageal reflux, if it's persistent, the body will actually convert the lower esophageal cells into stomach cells. The problem is that anytime you have these cells switching from one type to another, and sometimes they switch back, that's a precancerous state, because if they keep switching and they switch on to become a cancer cell and keep dividing, then they will be a cancer. So dysplasia is when a cell no longer looks exactly like it's supposed to. So a uterine cell looks a little bit more primitive, but it still definitely looks like a uterine cell. Again, these are not cancerous per se, but they're very concerning because the more they start looking primitive, the more they start becoming a risk for rapidly dividing and becoming a cancer cell. Anaplasia is when a cancer cell is formed, and so they are primitive looking. They're sometimes hard to identify as the site of the original cancer, depending on how differentiated they are. So you don't have to be completely undifferentiated to be a cancer, but they are always more undifferentiated than regular cells are. So they're looked at under the microscope. They look undifferentiated or poorly differentiated or fairly well differentiated, but still not as well differentiated as they should be to be a regular cell. So what causes the cells to kind of get crazy and become cancerous? We think that there are oncogenes. We think that there are genes that tell the body to turn on. We also think that there are epigenetic factors that will sometimes allow those genes to express and other times prevent them from being expressed. We know there's mutations. People that are exposed to radiation can get mutations and have an increased risk of cancer. And there's also some things that are promoters. Hormones, those kinds of things can really promote the growth of a cancer cell. Examples of mutators or promoters include some viruses. So we know that human papillomavirus is associated with cervical cancer. There's certain cancers that we think are related to blood cancers or leukemias. We said drugs and hormones. There's chemicals in the environment. Even basic dust can be irritating enough that it's an issue, but especially asbestos, nitrosamines, and all the chemicals in cigarettes. Radon exists naturally in the background. Sometimes it's in the water, sometimes it's in the bedrock. That increases the risk of cancer. And of course, the sun will actually damage cells and can result in skin cancers of either basal cell or even melanoma. So unmodifiable risks. It's interesting that poverty is included on this. We assume, yeah, you can't change your genes, you can't change your age, you can't change your gender/sex, basically because of hormones and things. They are theoretically can be modified, but for practical purposes, for the average person, it is not going to change. And that's the same way with poverty. Poverty is something that, yes, in a rare case, but the vast majority of people that are born poor will die poor. So other risk factors: stress, diet, occupation, infection, as we say, HPV, tobacco, alcohol and recreational drugs, obesity, and the sun. We talked about all those. So the cell cycle goes through various phases. It's initially resting, then it grows, and then it synthesizes DNA, and then it grows a little bit more, and then the cell splits. And normally when a cell's growing, like I say, it splits a certain number of times, somewhere between 15 and 25, and then it stops. That's the Hayflick phenomenon. But with some people, it doesn't stop. And in that case, the cells can just keep dividing and become cancerous. In malignancy, it's aggressive, there's no control, and the cells start to look irregular. And again, one of the things to decide whether a cancer is severe, we look at the size of the cancer, we look at where it is and what tissues it involves, but we also look at it under the microscope, and a well-differentiated cancer is generally going to do better than a poorly differentiated cancer. Carcinoma is a cancer of an epithelial tissue. Most organs have some epithelial tissue in them, so many times you'll have an adenocarcinoma, which is an organ and carcinoma combination. A sarcoma is a cancer of a connective tissue, so osteosarcoma. Most cancers are either going to have the name carcinoma or sarcoma in them. There are some less obvious ones: leukemias, lymphomas, and you just have to memorize which ones are a cancer and which ones are not. An osteoma is not a cancer. An osteosarcoma is a cancer. An adenoma is not a cancer. An adenocarcinoma is a cancer. Where do you get cancers? Basically any tissue in the body. Some are very rare. Heart tissue rarely becomes cancerous just because it doesn't have a lot of risk factors that can be exposed to. And various other tissues have varying levels of risk. You don't see spleen cancer very often, but you sometimes do. Other cancers like skin cancer, prostate cancer, breast cancer, colon cancer, lung cancer, all of those are relatively common. Now, we all know what METS is. METS is when a cancer goes from one place to another place. So if you have a cancer in your colon and it moves to your liver, that's metastasis. Or if it goes to your brain, that's metastasis. That's something you all know. How do you prevent cancers? Primary prevention is preventing something before it occurs. Secondary prevention is catching it in an early stage before it's caused problems for the organism. And then tertiary prevention is preventing the disability that goes along with the problem. So all of the things we're talking about here are actually sort of secondary prevention. Primary prevention would be staying out of the sun, wear sunblock. Once you actually get a cancer, you want to get it out of there, you want to detect it early, and then you do surgery, chemotherapy, or radiation. Different drugs interfere with different parts of the cell cycle. Therefore, you'll often have a cell regime or a cancer regime that has 3 or 4 drugs to it. It divides, kills any rapidly dividing cell in the body. Where do we have rapidly dividing cells? In our hair, in our GI tract, and in our sexual organs as far as producing eggs and sperm. Therefore, sometimes you have to bank some of the sperm or some of the eggs before you do these treatments. So we said hair, stomach, mucous membranes. You can get real irritation of the mouth, and then the reproductive cells. The white blood cells are also pretty dramatically affected in some people. This is much less of an issue than it used to be because we now have medications that will stimulate production of white blood cells. So there's lots of different cancers. They basically have the same pathology in common. In general, the treatments are similar, if not exactly the same. And again, some cancers respond to one kind of treatment. So let's talk a little bit about leukemias or liquid tumors. There's leukemia means white blood. So basically, a leukemia is a cancer in which the white blood cells are affected, and the white blood cells overgrow but never really become mature. So they're usually in that blast situation. So I've had patients come in, normal white count, of course, is maybe 5 to 12,000. I've had people with 30, 40, 50, even 100,000 white blood cells. Weirdly, they often have more infections because these white blood cells are in an immature form and are not very effective. There's 2 other kinds of liquid tumors that I think are more important. One is polycythemia vera. P. vera is a cancer of the red cells, and you have an overgrowth of red cells. The treatment is actually phlebotomies. Going back to the 15th century, we bleed people. That and hemochromatosis are about the only 2 conditions that I can think of that we still do that for. Another one is multiple myeloma. Multiple myeloma is a cancer of the plasma cells. Now, it does affect, you often get effects in your bones. You'll get little punched out areas. And the classic symptom of multiple myeloma is an elevated calcium level. So that's definitely that, and parathyroid hormone issues are the number 1 and number 2 things that will happen when you have elevated calcium level. It also can be metastasis. About 10% of the time it just goes away on its own. But an elevated calcium is a fairly ominous, concerning laboratory value. So the types of leukemias, they're either acute or chronic, and they're either the lymphocytic route or the myelocytic. All of the other types of white cells besides lymphocytes share a precursor stem cell, and so they're the myelogenous or the myelocytic leukemias. Because those cells do many more things than the lymphocytic cells, they're a little harder to treat and they're a little more ominous. So ALL tends to have a pretty good success rate for cure. CLL is often more of a chronic type illness that people have when they're older. It can progress and become more acute, but most people with CLL, we just watch them and keep an eye on them. So the TNM system, so tumors, nodes, and metastasis. Least severe is usually having a tumor, but no nodes and no metastasis. NX means we don't know yet, or we can't know. And so when you look at somebody, you do need to know or want to know their TNM status in regards to their tumor. The number one cancer killer, of course, is lung cancer. Kills lots and lots of people each year as smoking rates have stabilized. Rates should stabilize. Interestingly, smoking rates have not decreased over the past 15 to 20 years. They've just stabilized at about 12 to 15% of the population. Number two is different between men and women. For women, it's breast cancer. For men, it's prostate cancer. Note that it's a lot less than lung cancer. Both of them are less than a quarter chance of dying, but they are still substantial. The incidence of breast cancer is very high, but the mortality is not anywhere near what the incidence is. And again, men get prostate cancer. Colon cancer is actually the number two type of cancer because, you know, the overall numbers are greater than either prostate or breast. But it only kills 25 to 30,000 each for men and women, but that does add up to 50 to 60,000. We screen a lot for that. We have had substantial success in decreasing the death rate of that. It'll be interesting to see as new techniques like Cologuard come out, if that either makes things better, worse, or keeps it the same. So lung cancer, primary prevention, don't smoke. Secondary prevention is low-dose CT screening in people in their 40s, 50s, and 60s that have had a certain number of PAC years and have stopped within the past, I think it's 15 years. And then tertiary prevention is once you do find a tumor, trying to make sure that you minimize the impact on the organism. Colon cancer does seem to run in families. There's something called Lynch syndrome, which is associated with that, and ovarian cancer and a couple of other cancers. You can have people present with anemia, blood in their stools. A lot of them now we catch with screening. We think that maybe diet helps. We're not sure. We think that maybe cutting alcohol helps, but we do know that with secondary prevention, doing a colonoscopy, Cologuard, stool guaiacs, or something does seem to decrease death rates. If you have colon cancer, obviously you sometimes end up with a colostomy. And otomy just means incision in, and ectomy means removal, just to review the terminology. Breast cancers, about 200,000 women have it at any given time. Only about 40,000 die each year. Death rate's been pretty stable for many years, but is actually starting to show some decline over the past 10 to 15 years. It's interesting, mammograms really did not make a major impact, but some of the newer treatments seem to have decreased death rates. We don't know if there's really any primary prevention. Is it better to keep an ideal weight? Does smoking impact it? All of these things are good things to do for your overall health. They may actually decrease the risk of breast cancer, but we're really not sure if they do. So secondary prevention, breast self-exam. There's not really a whole lot of data that says that any women die any less frequently if they do breast self-exam. I always tell women that the key issue is, you know, just being aware of your breasts, and if you feel anything different, let us know. Whether you have to do a quote-unquote medical procedure every month and examine your breasts, I think is an open question. A lot of women are very committed to it, and if that's the case, then more power to them. Other women, I just think you're creating a lot of guilt that they don't do the exam, and there really isn't a whole lot of data that it makes a huge difference. Same thing with clinical breast exam. It's actually very interesting. If a woman is doing mammography, there does not seem to be any additional benefit to doing clinical breast exam. You know, again, if she feels a lump, that's a different thing. Mammography has substantial benefit after age 50. Before age 50, there's not a whole lot of proven value. Whether it's just hard to detect or what the issues are, we don't know. But definitely women should be screened after age 50. Most people do it between 40 and 50. Younger than that, you know, some people do a baseline at 35, but probably starting at 40 is fine. And again, lumpectomy may be just as effective as modified radical mastectomy. So this may be an example of trying to maintain function. Women that have a modified radical lose some of their muscle tissue, often end up with a lot of swelling. So by using the lumpectomy with radiation, we might actually decrease that disability. It's hard to convince women that that's as effective. Data seems to suggest that it is, but some women are like, nope, take it off. I want the whole thing off. And, you know, it's their choice, along with their surgeon, obviously. Sentinel node dissection, so usually they take the first node in the line. The more nodes you remove, the more likely you are to end up with chronic problems with lymphedema. About 250,000 men get prostate cancer every year. About 40,000 die. Is there a whole lot of value to early diagnosis? The United States Preventive Services Task Force would tell you no, that you do PSAs and testing, the same number of men die at the same age as they would have otherwise. There is an argument that maybe by getting early detection, that we will stop it from progressing into the bones, decrease the pain, and decrease disability. Somewhat of a different argument, but it may be, I think, a stronger case for screening to try to catch it early so that the treatment is easier and has less impact on the patient. Late treatment often requires hormone blockers, and the men become sterile as well as having erectile dysfunction. And again, with earlier treatment, you may be able to avoid that. The nerve-sparing robotic type surgeries seem to decrease the incidence of erectile dysfunction and incontinence, but they do still occur even with those surgeries, down in the single digits. But if you happen to be that guy, you're not very happy that you had that surgery, especially if the USPSTF tells you you won't live any longer. So melanoma is a skin cancer. About 8,000 people die each year of it. Early diagnosis in this case seems to make an enormous difference. If you're less than 3/4 of a millimeter, 5-year survival is 100%. If you're greater than 3 millimeters, that's less than half of that. So lots of different cancers. They all have the basic pathology, and certain types of cancers respond to one kind of treatment, but not others. I've got I think the quizzle, the 5th quizzle is on cancer. There's a chapter in your book, and we'll also have some cases on the discussion board. So that concludes this talk.